Welcome to Diagnostic Imaging's Weekly Scan. I'm Senior Editor Whitney Palmer, bringing you the top stories of the week. Before we get to our interview with Drs. Jennifer Hill from Radiology Partners and Amit Mahajan from Yale University School of Medicine about the neuroimaging findings and neurological implications associated with COVID-19 infection, here's the latest news. This week, the International Society for Magnetic Resonance in Medicine annual meeting brought us a wealth of research findings that will have future implications on the industry. According to one virtual poster, investigators from the University of Cambridge School of Clinical Medicine in the United Kingdom shared their findings that abbreviated MRI has comparable diagnostic performance to full protocol MRI with breast imaging. In a small study with 13 patients, they found that there was no significant difference in sensitivity, specificity, or area under the curve between the two protocols. As a result, they asserted, abbreviated protocols can be implemented to save both scan time and cost. Also at the ISMRM meeting, researchers from the National Institutes of Health presented a virtual poster that detailed a lower field strength MRI can provide effective cardiac imaging for patients who have suspected or known heart attack. To make this determination, they scanned 13 possible and confirmed heart attack patients with both a 0.55 Tesla MRI and a 1.5 Tesla MRI, and conducted late gadolinium enhancement imaging after 10 minutes of the administration of gadobutrol in both scans on a 17-segment model. They found that 0.55 Tesla scanner identified 59 segments with myocardial infarction, while the 1.5 Tesla scanner pinpointed 63 segments. They are planning future studies that include free breathing acquisition methods. The American Journal of Röntgenology also published news about gadolinium this week. Researchers from Princess Margaret Cancer Center in Toronto found that using a gadolinium-based contrast agent with diffusion tensor imaging does not change the accuracy of breast cancer diagnosis. In a study with 26 women who had BI-RAD scores of 0, 4, 5, and 6, investigators scanned patients with a 3 Tesla scanner twice, using the same diffusion tensor imaging sequence both before and immediately after breast dynamic contrast enhanced MRI. They diagnosed 58% of women with cancer, 13 with infiltrating ductal carcinoma, and 2 with ductal carcinoma in situ. Based on their analysis, they determined that the accuracy of breast cancer detection was not significantly different for unenhanced or contrast-enhanced datasets. Research also emerged this week that showed that CT illuminates the link between weight and brain function. In an article published in the Journal of Alzheimer's Disease, investigators from Amen Clinics, a national network of outpatient mental health clinics, discussed the connection between higher body mass index and greater brain dysfunction. They analyzed 35,000 functional neuroimaging SPECT scans from more than 17,000 people between the ages of 18 and 94. They determined that as a person's weight increased, the blood flow to his or her brain decreased. This phenomenon affected the areas of the brain most commonly associated with Alzheimer's: the temporal and parietal lobes, hippocampus, posterior cingulate gyrus, and precuneus. These findings support the growing notion that Alzheimer's could be a lifestyle disease, they said. And of course, COVID news is still here, just like the teleradiology that has been more widely implemented to ensure timely and safe imaging reads. In a short communication published in the Journal of the American College of Radiology, industry leaders from 4 institutions, Texas Health Presbyterian Dallas, New York University Langone, the University of California at San Diego, and Chambersburg Imaging Associates, discussed the feelings their providers have toward continuing remote reading long term. Everyone agreed that teleradiology is here to stay. But they did stress that a balance between in-person and off-site reading will be necessary. Not only will it ensure practices or groups can continue to foster professional relationships and fulfill the requirements of their contracts, but the greater flexibility will enable radiologists to maintain a better work-life balance and foster greater productivity. And finally this week, Diagnostic Imaging spoke with Dr. Jennifer Hill from Radiology Partners and Dr. Amit Mahajan from the Yale University School of Medicine about the growing body of neuroimaging findings and neurological impacts of COVID-19. They shared the most up-to-date information about the neurological effects and discussed what they have seen in their personal practice. Here's what they had to say. Well, many thanks to both of you, Dr. Mahajan and Dr. Hill, for joining me today. I really appreciate you both taking the time.
Our pleasure.
Our pleasure. Absolutely.
Wonderful. Well, now, as you both have experienced, and as we are certainly hearing more about in the news recently, the neurological impacts of COVID are a lot more intense than what we originally thought they were at the beginning of the pandemic. So can you both give me an idea of how prevalent these neurological impacts and injuries are in the patients who are positive for the virus? And either one can jump in first. Dr. Mahajan, if you'd like to.
So yeah, the neurological complications are not a very common manifestation of COVID by itself, of all COVID infections, but it's definitely a very significant when it happens. And it's especially important for severe COVID infections in people who have very high elevated levels of D-dimers on presentation. And those people are especially seem to be at prone to develop the risks of neurological disease in the short term and the long term.
All right. Dr. Hiller, are you seeing the same thing?
I am seeing the same thing. I think part of the issue as well, at least for us in our practice in the beginning, was that we weren't imaging these COVID patients. We didn't have enough PPE. We were worried about controlling the infection within the MRI unit. So you had to do special cleaning for that. So I think that we might not have seen as much as we could have had it been easier to image the patients. Having said that, definitely as time has progressed over the last few months, we have seen some very serious complications from COVID. And I agree that it's typically within the patients that are sicker and have more of an inflammatory response or hypercoagulable type state. We're finding that as well.
Right. Well, before we jump into some of the specifics of what actually happens to these patients, from what you both are seeing, are there certain factors or characteristics in these patients who do develop neurological conditions that we're starting to see are kind of a common theme throughout these individuals? You know, who might be more prone to developing this?
Yeah, I think it's the same theme which is kind of all over all the hyperinflammatory response which is happening, and the cytokine release syndrome which is being described in patients with COVID infections. And the same risk factors like hypertension, diabetes seem to be making them more prone to, and obesity seem to be making them more prone to develop these complications. And also, all these neurological complications of thrombosis and their effects on the brain itself. I don't know if you have anything else to add, Jennifer.
No, I would concur with that. I think we definitely have seen hypertension, diabetes, obesity in our patients. That certainly have heard anecdotes about younger healthy patients and showing up with stroke in the ER, but I have not yet seen that.
Right. Well, is there a point at which where this becomes evident where we might be thinking that it is time to image and start looking for these neurological impacts and injuries?
I mean, it's hard to generalize across the country because I think there are different levels of threshold by which people are imaging. So, I mean, some hospitals are not imaging enough, and then some people are more have been more amenable to doing these MRIs. And I think in New York City, there were some hospitals who have really been spearheading the use of MR in these patients. And I mean, we have been increasing our imaging, but I think the usage of MR around the country is not universal. And so it's hard to predict like when to do, I mean, whether we should increase imaging or not. I mean, I think the best way we have dealt with this is by looking at neurological symptoms. And if there are significant neurological symptoms, then people have been more likely to go in and do imaging and find these findings which have been described in the last few months, that since the epidemic started. Is that your experience as well, Jen?
Yeah, that is. I think there's sort of two camps almost. There are patients who are presenting to our ERs as a code stroke. We work them up for that. We find an embolic stroke. And then you look at the lung apices on your CT angiogram, and sure enough, you see findings that are very suspicious for COVID. So we almost diagnose it before COVID is diagnosed. So that is sort of one bucket of patients that we are seeing. And then the other bucket is sort of like you talk about, when the clinicians feel like there's more going on here, I think it's worth the risk of imaging the patient, then we will image them. But it's not ubiquitous by any means. And it is sort of a big deal to get MRIs in these patients.
Absolutely. Well, you kind of touched on the next question that I was going to ask Dr. Hill. When it comes to these patients and how they present, what are you initially seeing with these individuals when they come to you, and then kind of as you dig a little bit deeper, what are you finding when imaging kind of comes into play?
Yeah, I think, you know, as a radiologist, we're sort of, at least I like to think of ourselves as detectives, and let's find Waldo, so to speak. And so we get, you know, we kind of like when we see patients that come in with neurologic deficits, and then we're able to find that neurologic problem, whether it's a stroke or a hemorrhage, but then, you know, you follow up on the chest x-ray that was done at the same time, and you start to see these peripheral opacities, and you kind of start to put the picture together for the ER doctors. Definitely have cases of that. Have many cases where, you know, not neuro, but basically where you do an abdomen and pelvis CT and you see the lung bases. So you kind of, you know, they come in with maybe a headache, or they come in with a stroke symptom or abdominal pain, and you end up finding COVID. So we definitely have those, a lot of those patients that we see and share, but we have not written them up for a paper or anything like that. I know other people are doing that across the country.
Has that been your experience, Dr. Mahajan, or are there other things?
Yeah, so there have been a lot of people with stroke, especially young people with stroke, reported out of New York City when the epidemic started. And since then, there's been a whole bunch of reports around the country of different kind of neurological manifestations, which include basically strokes and other inflammatory syndromes like necrotizing encephalitis, and also various kinds of Guillain-Barré syndrome and Miller-Fisher variant, and other kinds of you know, neuropathies and brain involvement that have been described. And this was described even in Italy as well, and even there have been some Chinese reports as well. But the common theme, I think, has been that most of them seem to be due to thrombosis and its side effects, thrombosis leading to stroke and stroke-like manifestations in these patients. But a lot of them also present with other non-specific neurological manifestations. I mean, there has been a big concern that this virus could be invading the brain somehow and causing brain manifestations. Although whatever pathologist reports I've seen on autopsies being done, they have not been reporting brain involvement as such. What they have been saying that there is small vessel involvement of the brain, that the vessels of the brain are being involved and cause some degree of endothelial damage or blood-brain barrier damage, but not really brain invasion as such. So that's a good thing, that at least it's not like poliomyelitis or something in which the brain is involved, or encephalitis. So it's more like something which is happening in the rest of the body, and the brain is kind of damaged as a bystander of the systemic inflammation.
When it comes to those particular types of findings, is there, I guess, a new cadre of up-to-date information that we can provide for radiologists when we think about endothelial damage or thoracic injury, anything along those lines?
I mean, I think somehow radiology is somewhat shielded from the front lines a little bit. So we are a little bit of protected from what's happening outside, but we do get the impact of that. And I think, as Dr. Hill pointed out, we get all these stroke codes in the hospitals, and people thinking that this could be due to just garden variety stroke in an older patient, but it could be a nursing home patient who had COVID and has subsequently presented like that. So I think keeping a high risk, high degree of suspicion is the best way. And if you have concerning findings on the parts of the chest as we image incidentally, I think that will be, that is the way to kind of direct the care of the patient.
Anything that you can add, Dr. Hill?
Yeah, no, I think that what we've been doing internally in our group is sharing cases, and I think that's part of what we hope to do with the Radiology Partners webinar coming up, is to show some of the more common, I mean, it's still not super common, but what we do see in private practice. And one of the things that I had seen early on in COVID was posterior reversible encephalopathy syndrome. And it had been interesting because the clinicians had been going along with saying, oh, this is a COVID patient, I think embolic strokes. But if once you really looked at it, it was like, no, this patient needs an MRI. I think this is actually vasogenic edema, actually posterior reversible encephalopathy syndrome. So we were able to get an MRI on that patient and found that. And then I think within a month or two, started to see other people writing about that in the literature, that yes, this has been associated with PRES. And other injury like cytotoxic lesions of the corpus callosum or demyelinating type processes. And so it's really opened our eyes as neuroradiologists to start to look for these things, and hopefully be able to work with the clinicians so that we can guide a little bit. Is this, antithrombotics? Is it steroids? What, we're trying to figure out how to help these people, help the patients.
Absolutely. Well, again, that dovetails into another question that I had, specifically when it comes to what these imaging studies are showing. What are I guess, the more common injuries, the neurological injuries that you're seeing kind of manifest and show up on these scans, whether they're specifically, directly related to COVID or whether or not we can tell that?
That's the big question, right? I think Dr. Mahajan was talking about that. Is I think that there is there is a hypercoagulable kind of thrombotic state where, you actually are creating clots in the body, and that does affect the brain for sure. So I think that we see that. That's probably what we would see most commonly. I think then the cytokine storm, I think, can lead to probably some injuries more related to the cytotoxic lesions of the corpus callosum, maybe even PRES, where you start to injure the endothelium and you can't auto-regulate the intracranial blood pressure. So I think there are maybe indirect effects from COVID that do affect the brain. And I am waiting as well to see if there's actually going to be some sort of neuronal invasion by the virus. Theoretically, it's been talked about being possible, but I've yet to see that that's been proven as well.
Well, then taking a step back and thinking more specifically about imaging, like you said, Dr. Mahajan, MRI isn't necessarily readily available everywhere. So from that perspective, what are the modalities and scans that you are relying most on, or that you found colleagues throughout the country are finding to be the most helpful and the most informative when it comes to dealing with patients who present with these neurological symptoms and conditions?
Yeah, so when the epidemic initially started in China, I think they have much more access to CAT scans somehow as compared to what we initially thought. And they seem to be, in fact, when the epidemic started in China, they were like screening everyone for with CAT scans to look for COVID infection. And in fact, there was a very interesting point in February when suddenly in one day, the number of cases jumped by a huge %. And that is because this changed their diagnosis from based upon the PCR to CT diagnosis. So that in one change, that big jump that happened was because they changed the criteria to CT diagnosis. So the thing is, so I'm glad the ACR, when it came out with its guidelines, they did not say, no, let's do CT on all these patients. I think that was, that was a great step taken by ACR, in which they did not go by what the Chinese clinicians were telling us at that time. And following that, I think we stuck to chest x-rays for a few months and using CT only sparingly. And we were still doing CTAs in patients for strokes and neurological symptoms and all that. And at that point, we discovered all the incidental findings on the chest CTs, on those neck CTs that we had. And people have published on that as well. So from that point, MR, as we said before, we have tried to not open up MR to every patient possible, but we have tried to open it up selectively to patients who are neurologically impaired. And I think I've reached out to my colleagues to make sure that if there is a person who definitely needs an MR, we make sure that we do those scans and not say no to them. And we have come up with protocols within the hospital to image these patients in the appropriate fashion. So, I mean, you can always do a CT, which is much less time consuming than the MR. And we have been doing that as well. And in fact, I think the CT techs in our hospital were especially very kind of quick to understand the concepts involved with infection control. And in fact, we were doing CTAs at the peak of the epidemic with like a mask on patients' face. And I think that worked out well. And most techs did fine with that protocol that we had followed. And so now I think we are much more comfortable as far as the infection control procedures are in place, and people are doing even procedures like LPs and Myelos as well in the hospital settings if we have to. So I think overall a judicious use of resources that we have, which include X-rays, CAT scans, if we can get away with CAT scan, and then use MR only if required or to solve a particular question or something.
And has that been your experience as well, Dr. Hill?
Exactly, yes. We have definitely, CT was used early on, somewhat judiciously, then more and more. We had sort of, I think many practices across the country had a precipitous drop in stroke patients actually showing up to the ER. So early on probably in March and April, our stroke volumes decreased tremendously. And so we weren't imaging very many of the patients at all. And then all of a sudden the stroke patients started coming back, and we were using CT angiography, CT perfusion. And again, the MRIs only when it was a difficult clinical question, or we really just needed to get to the bottom of it.
Well, then thinking about providers in the community, for those who, maybe this is, truly month 4 and they're knee deep in this, or they've only started feeling the impact over the last few weeks, like, various parts of the country have. For those providers, what do these radiologists need to know to kind of keep their eyes open for when they're potentially faced with a COVID positive patient who is experiencing a neurological impact?
I think using adequate infection control measures, and putting in protocols of infection control in place, with adequate PPE if available. I think that's the key to making sure that we are all safe as radiologists and radiology techs as well. I think that's the way to go, is make sure that we have enough PPE available in our radiology areas, and we should fight for them if we have to, and put in protocols in place for infection control both before and after the patient is scanned. And I think that is the way to make sure that we image the patients with neurological symptoms and not expose our radiology techs to unnecessary risk from these patients.
No, I think that's an excellent point. And I think we've been moving, we had many practices experienced the dramatic drop in outpatient volumes. And we've been slowly kind of bringing our outpatient practices is coming back. And part of the reason it is coming back is because of these safety measures we take in place and the communication with the community physicians who are referring their patients to us, that we will screen your patients, we will take measures to protect the staff and your patients. So definitely, even on the outpatient world, things have changed quite a bit because of that. And inpatient, of course, much more likely to be imaging COVID positive patients. So PPE is absolutely critical.
Another thing which our hospital has done is create, for outpatient imaging, have created this hot zones and cold zones in which only patients who are proven COVID-free will go there. And other ones which are suspect could go to the other place. So I think that has helped as well in our setup.
Is there anything specifically, though, about the patient themselves, I guess, that the radiologist should kind of keep their eyes open for to tip them off that there may be something particularly different about this patient, or there may be extra, like you said, safety protocols that they all of a sudden need to be sure they put in place?
We have done. I'm sorry.
No,
So in the I mean, I do some procedures as well, so I can tell you my experience from that is like, for inpatients, we try to do their COVID testing before they get admitted. So everyone gets tested at admission. And then for outpatients, we have not been testing them. And we make sure that everyone who does the procedure has enough PPE. So fortunately, our infection rates have gone down. So we have adequate PPE for now. So I think that's, I mean, we are using that kind of, I mean, people who need anesthesia and sedation definitely get a COVID test done. But short of that, people, otherwise we're just using PPE with our patients too. And we definitely, someone calls them a day before or to make sure there are no symptoms happening. And even that day, they will be asked symptoms for the presence of symptoms of fever or any cough or any other similar things that they have before they come into the radiology suite.
Sounds very similar to what we're doing. Yes.
Well, then thinking about, I guess, instances where a neurological condition can mimic something else. And I'm kind of thinking about a parallel here with what we're seeing with pediatric patients with MIS-C, and how in some instances it's been misconstrued as Kawasaki disease or things along those lines. Is that a possibility with neurological complications in these patients? Are we seeing instances where providers are thinking maybe it's one thing and then it's COVID related, or any of those situations where we may have difficulty in diagnosis or poor detection?
I will say that we have COVID on the brain, so to speak. I mean, we are definitely, almost to the point where, we had a patient with press the other day, and it turned out she had eclampsia. She was pregnant, and we had called up saying, hey, we think this patient has COVID. They're like, no. So it may be on the other side of things where, we're really very heightened to the possibilities of COVID and what it can look like. So I don't know that you've had other experiences.
No, I don't think we have had a similar situation in which I think, yeah, we are very sensitized to the presence of COVID infection. So people have been, somewhat, I think, overcalling it on CTAs now. And I see like, if they feel like they have to call it to make sure that if they see anything on the lung, they have to make sure it's not COVID before he gets admitted to the hospital. So I think that's good that we're sensitized and we are careful to the presence of infection. And then, it's just like TB in the past. I think everyone in the past, when they had a little positive PPD in the infectious disease world, everyone would get just isolated and ruled out for TB for 3 days with 3 sputum specimens before their precautions were opened up. So I have a feeling this is the way to kind of deal with it. It's like, just make sure it is negative and overcall it if you have to. I think that's a better thing than not give care to these patients. I think that'll be so bad.
Absolutely. Well, like you said, a lot of providers have COVID on the brain, as it were. So given that, how much are you seeing that imaging is really making an impact in determining management of care or maybe changing treatment protocols?
Yeah, I think the biggest thing that we have found is really, patients coming in with, the chest x-rays, at least in Los Angeles, seem to be quite positive, far more positive than we're used to seeing. And so I think, we've been working with our ER doctors to let them know right away that we have findings that are concerning for COVID, and kind of moving the patient along that way. So I think that's something that has been very, very unique about this time period. Is I don't remember a time seeing so many positive chest x-rays out of the emergency room. So I think we're having an impact there. Again, thrilled that ACR didn't come out and say we should CT everybody and give everybody chest x-rays. we wouldn't be able to keep up, and I'm not sure that's necessary. But the cases that are done are, I think we're making a big impact that way. And then again, I think, looking for, we're doing a lot of ultrasounds, CT pulmonary angiograms, CT angiograms of the head and neck, and we are finding abnormalities and clearly trying to triage and make decisions quickly based on those findings.
Has that been your experience, Dr. Mahajan?
Yeah, definitely. And it's a similar, I think we are all going through that same phase. And as I said, I mean, overcalling somewhat, but that's okay. I think that's better to overcall than miss patients with potential COVID infection. I mean, I think we should be getting ready for the second wave now. So although I know that the first wave has not ended, but it's better to be safe. I mean, especially in our area in the Northeast, I think everyone is still on masks, so that's good, and which is a good thing, and everyone is sensitized to that. And keeping it that way, and make sure the second wave doesn't come back. I mean, we're already seeing the end of summer now and the beginning of fall, so people are already starting to worry about it. So keeping the vigilance on and not letting go of our goal that this is not the end, there's going to be more, and keeping an eye on that ball, I think will be critical to make sure that we control the second wave before it hits us really bad.
All right. Well, I appreciate this. This has been a wealth of information. Are there any takeaway messages that either of you would like to leave our audience with, for the care that they need to provide going forward? Any tips or words of wisdom?
No, but I will tell you one thing I am interested in, and that will be sort of if we get to the point where we can start to perhaps image and work with our neurologist colleagues to determine the long-term impact of COVID. Right now, we're seeing acute impacts on the brain. But talking to some of my colleagues in the clinical world, these patients are struggling with headaches and memory loss and things months after the infection, and trying to also make sure that we spend some time trying to see, is there anything going on there that radiology can help with, and really what is going on there. So to me, that's something down the road, and I look forward to working on that as well.
Yeah, my only, I think I try to keep an eye on my eye on the ball. So that's to basically make sure that we control the second wave, or whenever the new wave comes, so that we can control the infection there. And I mean, I think keeping an eye on the neurological manifestations and the range of neurological manifestations that are happening will be important. So I think that will be my message is know what you have and be ready for whatever comes, whether it be press or something else.
All right, perfect. Well, again, thank you both so much for taking the time to talk with me this evening. I greatly appreciate it.
Thank you.
Thank you.